Support for your public radio station comes from our members and from Renaissance Academy Charter School of the Arts, a public elementary school in Rochester with an arts-integrated curriculum designed to help children unlock neural pathways, overcome trauma, and thrive. Community support helps sustain programs and resources. More at renacad.org. And Labella Associates, pursuit of partnership for more than 40 years, offering services in the development of buildings, infrastructure, environmental, and
4, 3, 2.
c.com.
From WXXI News, this is Connections. I'm Evan Dawson. Our connection this hour was made in a delivery room during the chaos of labor. Over the past 25 years, a growing number of Americans have had the assistance of doulas during labor and delivery. Not a majority, but that number has crept upward. Often doulas can help with the pain of labor, but they can also do a lot more than that. 80% of pregnancy-related deaths are preventable, but as the CDC reports, hundreds of American women die each year while giving birth or in the year after giving birth. Thousands of additional mothers experience short or long-term health challenges. Certain factors prevent many women from receiving the care they need, leading to disparities along racial lines. So what can be done to mitigate adverse conditions and prevent unnecessary deaths? We explore this question from Common Ground Health in Rochester as part of this special on-the-road edition of Connections. Our guests are talking about barriers to care. We'll talk about the difference between doulas, midwives, OBs. We'll answer your questions about that. And we'll talk about how our guests think that we can achieve better outcomes here for moms of all backgrounds. Again, we are coming to you from the combined entity of Common Ground Health, Finger Lakes Performing Provider System, and Rochester Rio in Rochester. Let me welcome our guests now going down the table. Actually, starting on the far side, Dr. Elizabeth Bostock is an obstetrician gynecologist with Rochester Regional Health. Welcome. Thanks for being here.
Thank you.
In the middle of the table, hello, mother of three, Candace Williams, who's going to talk about her experience as a client of Royalty Birth Services. Welcome. Thank you for being here.
Thank you.
And the owner of Royalty Birth Services and a certified doula, Phyllis Sharp. Welcome back. Nice to see you.
Nice to see you again as well.
So once again, let's welcome the live audience, and I'll have the audience welcome this panel. Thanks for being here. As always, we will welcome feedback from the live audience here in the room, from listeners, and from viewers on YouTube. And we'll incorporate some of your feedback as we go throughout the hour. Let me start with this, Dr. Bostock. You have been in delivery rooms for a number of years now. And before the program, I was asking you, really in the last generation, what's the difference in terms of how often you see a doula during labor and delivery? What does that look like today?
I think we are seeing significantly more doulas than we did a decade ago or 2 decades ago. I think the relationship between doulas and the healthcare team in the hospitals is significantly more collaborative than it was 2 decades ago. And so that's to everyone's benefit.
Yeah, my first son was born in 2012, and I was told, hey, look, if you get a doula, it depends on the doctor, but they might not love having a doula in the room. This was 14 years ago. I don't know exactly what that was based on, and I don't know the dynamics. You're smiling at me kind of knowingly, but what are those dynamics, and is there any resistance? Has there been resistance over the years to doulas being there?
I think doulas 15 years ago were different than doulas are today, and Phyllis can probably answer this question even better than I can, but doulas used to be a barrier between the patient and the in-hospital team. They were almost like a fierce lion at the door protecting people from the healthcare team. And that set up a dynamic that was very difficult to navigate for the woman and for the healthcare team. I think today the doula practice has evolved to be more of a collaborative connector, bridge kind of relationship between patients and healthcare systems and healthcare teams. And that's why today you're seeing a resurgence of the doula movement, because it actually works productively for the patient and for the healthcare system to produce better outcomes.
To be clear, in the delivery room, you want a doula there.
I do. And I don't know any doctors at this point who do not.
Wow. Okay. So we'll talk about the benefits coming up here. This is a great chance to ask Phyllis, as a certified doula, what it is you do, because over the years since you became a certified doula, I'm sure people have said, what is that exactly? And does that mean you're a midwife? Does that mean you're something else? So why don't you take us through the definition of what a doula is? How long have you been doing it?
I've been a full-time doula for 7 years. We are not medical. We are not a midwife. We don't catch babies. We don't take blood pressures. So we don't do those medical things. We don't take temperatures. We don't do any of that stuff. But we're there to support them physically, mentally. We're there to really help them, educate them as well too, to make sure that they understand, what's going to happen in the hospital, questions they can ask their doctors. We can go to doctor's appointments with them, ultrasounds with them, all of those different things that are there to really be that support for them, but we're just not medical.
How many births have you been there for?
Over 400.
Over 400?
Mm-hmm.
Do you remember the first?
Yes.
Was it nervous for you?
I'll say my two first. My first was when I was 17, and I went in with my older sister. And my first as being with someone I did not know was 7 years ago. So both a little nervous about, but being with your sister, you know them very well. And being with someone you don't know, at that particular time it was hard because we went through COVID and all of those things as well too. So it was the relationship, we had to build a relationship. And then we really were in it to win it, And so it's very nerve-wracking when you're in the room with someone and different things are going on and it's your first time, really kind of like first time, being with a couple that's not your family member.
And have you seen in 7 years,
Mm-hmm.
have you seen a change in the dynamics of the OBs who you work with and the other specialists in the hospital to your presence?
Yes, a huge difference.
More welcoming.
More welcoming, absolutely. It was very difficult in the beginning, and coming in as a new doula and then listening to other doulas around me, you can see where the problems came from, right? And so why doctors were so resistant to doulas as well too. It was, like she said, it was almost like a fight. It was like a cat fight. We are there to advocate, help protect them, but we shouldn't be hovering over. We don't tell them what to do. We don't tell the couple what to do. We don't help them we don't make decisions for them, but we educate them so they can make informed decisions on their own.
You don't contradict the doctors.
That has totally changed. So for me, it's like, what does doctor thinks they should have a C-section? Why? So we want to make sure they're asking those questions. Why? What I think that's a good idea. What is going on with the patient as well too. And so I'm there to help really bridge that gap because no one goes into the hospital expecting to have a C-section or even want a C-section. But if that happens, we want to be able to make sure that they totally understand why they need it.
Dr. Bostock, you want to do a quick definition of OB, midwife, doula differences?
So an obstetrician has gone to medical school for 4 years and done a 4-year residency. They are there for clinical work, determination, emergencies, cesarean sections. They can do regular vaginal deliveries, but their real expertise is in managing high risk and managing problems. Midwives are a set of providers who have been educated either with a nursing degree or some other kind of degree like a PA, for instance, who then goes on to midwifery school and midwifery training in how to provide physiologic birth and capture babies in the safest possible way. Their practice often really emphasizes continuity of care. And so, not that obstetricians don't do this, they sometimes really do, but it is the hallmark of midwifery care to have continuity from the prenatal period through delivery and into the postnatal period. Doulas, on the other hand, are certified and trained in how to be advocates for patients, how to understand the process of birth so that they can help the people that they're caring for advocate appropriately for themselves and navigate the process, and to be that bridge to the home environment. One of the real beauties of doulas in my mind is that they go into the home and they can see what's happening in the home. So for example, in that postpartum period, that's so very high risk for women, they are there and they can see what's happening and they can see the warning signs and get people help before there are really significant problems that develop.
And part of the reason we're having this conversation this hour is because the Common Ground Health team has been working on data, and we've been talking about disparities these 2 hours. So we talked diabetes last hour. There are serious disparities that we're going to talk about in a moment with all three of our guests. And those disparities often show up along racial lines. There's also sort of an unfinished or unpublished community report that might be forthcoming from the Common Ground Health team as well. Doctor, is that right?
That is right. Common Ground Health, in collaboration with FLIPS and URMC, has embarked on a project, the Maternal Health Equity Project, which has been facilitated by Dr. Twyla Dillion, who's not here today, so I'm not going to speak for her, but I do want to lift her up because she is a really significant member of our community in this space. And what this study did was it gathered 28 moms who'd had births in the last several years and asked specific questions to facilitate understanding what Black moms were experiencing in the community that was a problem and was creating problems. And what has come out of that, we've only done the first really initial analysis of that, but what comes out of that is that Black moms are experiencing gaps in prenatal care and getting access to care. They're experiencing gaps in postpartum care and feeling like they're dropped as soon as they give birth, right? So we're treating birth as the main event and forgetting that, like, once you birth this human, right, you got to go through the process of raising the human, and we aren't helping people with that process. And Black women are feeling very isolated in that year or many years after they give birth to a child, right? There's not as much community out there as there used to be, and the health system does nothing to aid in that. So one of the things that we're hearing is that Black women really want a place to form community. And again, this becomes a place where the doula community can really be a very significant part of what we intervene with.
Yeah, I think, and maybe Candace can relate to this, anybody who's taken a baby home from a hospital has a moment going, are you sure you're giving me this baby to just take home? Like, that's it? Have you had that experience before? Does it amaze you every time that you're just allowed to take the baby home? That's it?
Yeah, I mean, even from the point of putting the car seat in for the first time, it's like, okay, it's real now. It's time to go.
So, and so it's real for everybody, but the point of what Dr. Bostock is talking about is really where that care often stops or where the gaps fill in. And doctor, is it true that not only the post-birth care is lacking for Black women and Black families, but is it also true that when you see a doula, it's more likely per capita to be white families, white women delivering with a doula assisting? Is that true?
That is true. It is more likely for women of economic means to have a doula.
Okay. So we'll welcome feedback. Listeners, really, if you've had a doula, if you've had an experience that you want to share, you want to email the program, connections@wxxi.org. If there was something missing or something that really bothered you about the experience or you wish had gone better, not only during delivery, but to Dr. Bostock's point, what happens after, we'll take your feedback coming up as well. Candace is a mother of 3. And how old are your children?
1, 3, and 5.
How are they doing?
They're great. 2 are in daycare, 1's at school.
Okay. And, 5 years ago, 6 years ago, before you became a mother for the first time, take me through what you knew about doulas and what your preparation was like for that.
Well, in some ways, I'm very much of my generation. I went to Instagram, and there was a family on there. Their name are the Ellises, and I saw their entire birthing process from when she was pregnant, all of the different things she was doing. She had a doula, and how she went through her natural birthing process. And I thought to myself, wow, that seems like that would be the way to go. It seems safe. She seemed supported. She seemed taken care of. And so in the back of my mind, that's something that I always wanted to do. But then, when the time did come for me and I told my family about this birthing at home situation, they were like, definitely not. You need to be at the hospital. And so my take was, all right, I'll go to the hospital, but I'm going to have a doula. And that's kind of how things started for me.
And who did you find to do that?
Phyllis.
You found Phyllis. How did you find Phyllis?
Well, actually, through family. So my husband is her cousin, so now we're family.
So now you're all family. Okay. And were you able to sort of mentally part with the idea of a home birth? I mean, did you feel any sort of way about giving up that experience?
I did feel a way. I was really married to it, but the majority of people in my life, they were just like, if something goes wrong, then what you gonna do? You gonna end up at the hospital anyway. And so I just went that route.
Okay. Any regrets?
No.
Okay. So you meet Phyllis, and before I ask Phyllis about the process, why don't you tell me about that process of getting to know her? She gets to know you. And when you talk to people who say, well, what does that mean? Did they just show up on the day of the birth? I know that's not the case. What was that relationship building like for you?
It was great. Way before it was my due date, she came to the house and we would have different talks. She would walk me through different scenarios, my birth plan.
Why are you laughing?
Because, you know, when it's your first baby, you want to do all the things and you feel like, yes, okay, I need candles, I need music, I need this, that, and the third. But then once you're there and then after you have multiple,
Your
it's just
birth plan had like different chapters? It's like a full book?
For those who know me, they know that I like to plan. So it was too much, but we got through it.
Well, let's ask Phyllis about that. So I'm sure you've seen all kinds of different birth plans or just ideas about what they wanted. And here's this first-time mom-to-be. She's got all these ideas. That's pretty common, and that's understandable, right?
Yeah.
So what'd you tell her?
We'll see.
Did you tell her you need an editor?
I think that for a lot of first-time moms, you know, like she said, Instagram. We're looking at Instagram, and they plan all these things. They don't even turn their music on half the time when we get to the hospital. You know, it's really the things that we desire, but it's not. We don't know how we're going to feel when we get into that space when we're in labor. We may not want anybody touching us, but we're talking about all these different massages. You know, all these different things that we're talking about before. But when we get into the midst of it, it's like, you know, we're trying to figure out like what we really want and what we really need in that space as well too.
So a lot of playlists never get played? Is that what you're saying?
A lot of playlists never get played.
Candace, you had a playlist? You have had all three? Did you have playlists for?
No, okay. So my first one, I had a playlist. The other two, they didn't get nothing. They were too fast.
What was the first birth experience like for you?
Man, it was a lot. So I was in labor. Phyllis, how long was I in labor? Over, I think almost 2 days. 2 days? Mm-hmm. Yeah. So I ended up having to be induced because my due date came and went, and they were just like, all right, let's get this going. But that whole process, beforehand, I was thinking, I'm going to have a natural birth. I am not doing an epidural. But as I mentally prepared for that first full day, which was rough, but I was able to ride through the contractions. But that second day came.
It was not fun.
Yeah.
No. Her baby was sunny side up, so which made it a little bit difficult. She had a lot of back labor. And it was a slow progress with baby coming down. So that's why her labor took a lot longer than it should have. And I remember talking to her husband on the phone, and I was like, how's she doing? She doing okay? And he's like, yes, she's doing okay. And I can hear her, Phyllis! Phyllis! I'm like, she is not doing okay.
No, I was not.
Listen, how was he doing? Nobody ever asked about the dad. Oh, he was okay.
He was fine.
He was doing great. But no, she was in pain, you know, and she was like, I don't know, should I get an epidural? I'm like, get it if you want it. If you need to get it. And she finally got it, and then we went through the rest. But it was a lot. It was a lot for her.
But on the subject of an epidural, let me just ask, because I understand that for some mothers, there's a real desire to avoid it. There's a desire to avoid it, to want to experience birth in its fullness. There's a desire to avoid it for maybe other reasons. And it can be hard in that moment where you feel like you're breaking down. And I mean, like, so we're laughing now, and I'm glad you're able to laugh about it now. I know in the moment that can be a hard decision. Was it hard for you, or did you get to a point where it's like, whatever, just do it?
So leading up to it, it was a hard decision because you talk to other mothers about their birthing experience, and someone close to me, when they had an epidural, it left them temporarily paralyzed for a few days. And I was just like, I don't want to have any experience anything close to that. So I was going to try to do it naturally for as long as I could, but the pain was way too much.
Dr. Bostock, is that, I mean, I know that's not common, but that could happen with epidural?
It could. It's an extremely uncommon occurrence.
I think
right?
part of the problem is when people go into a situation for the first time, often what ends up getting into you, whether it's Instagram or your circle of friends, you end up getting the stories that sound either really optimistic or really pessimistic, but they're often really rare. The first friend of mine, when I was in early adulthood, who had a child, she described her labor as being like 15 minutes long and like a mildly uncomfortable bowel movement. And I thought, that's an amazing way to describe it. Birth sounds easy, you know? I don't know what women complain about. And, you know, so you can hear the extremes, and then you get this idea in your head, and if it's not what you expect or what social media tells you, it can be really hard. But I didn't want people to think that the paralysis, while possible, is common. At the same time, I get why that scared you. So you go through that, and you end up getting the epidural.
Yep.
Did it help?
Yes. Okay. Night and day.
And the rest of the process was okay?
Oh, yeah, it was smooth sailing.
Okay. And so then when you end up pregnant again, you knew you were going back for the same doula, but how different was your mindset as a mother going into the second?
I was less afraid. Like, there were so many factors during that first pregnancy that had me terrified. Because, again, when I had my first child, that was January 2021. So that was still when you had to wear a mask.
Oh, yeah. Yeah.
And in my mind at that time, I was like, am I going to have to push this baby out wearing a mask? But that obviously didn't happen. But, yeah, the second time around, I kind of had an idea of what to expect. And, you know, working with Phyllis, complete trust, and same medical team. And I know a lot of women aren't always as blessed as I was to have a doctor who looks like me and also have a doula who looks like me, that adds to those layers of feeling like I'm protected. Because as a mom, especially when you know the Black maternal health crisis is bubbling up, along with all the other things that are happening, it's comforting to know that who's working on you looks at you and can see their daughter or can see their niece. Like, I remember going to doctor's appointments, and she'll tell me different things like, oh, yeah, just say you're my niece. Like, my OB GYN would do that.
Wow.
And so I just felt completely confident with that, and having Phyllis with me, no fear.
So one thing that I heard years ago, Phyllis, was that if doulas were a medication, it would be illegal to withhold it, that's how valuable doulas can be. When you look at the disparities that not only Common Ground's reported on, but the CDC is concerned about, doctors across the country are concerned about, how concerned are you about this community and the disparities we have, and what do you think can start to address it?
Number one, the disparities in our community, the numbers haven't changed really. And what I'm going to talk about me personally, have been working on is really increasing the relationship between doulas and doctors and midwives and nursing staff. Doulas can't do it alone. We can't change a system, right, from the outside. The system needs to be changed from the inside. And that's something that we can't do. And I think sometimes that people put all of that on the shoulder of a doula, that we can make all of these changes, and we have to do it together. We can't do it apart or separate. And for me, that's what I see, is that working together, trying to change the system from the inside out, and us really being able to make a huge difference in the impact of our relationships with each other. Like she said, 20 years ago, the relationship was terrible between doulas and docs, and now it's getting a lot better. But we have to be very intentional about that, because we can't, like I said, doulas can't do it alone. We're in the room, and I think a lot of times we can just be that witness in the room as well too. We're there, we're looking, we're watching some of the things that happen, even with her first birth. And I don't know if she just had a premonition or something. She just kept saying, Phyllis, don't let them cut me. Phyllis, don't let them cut me. I'm like, okay. And her doctor had the scissors, was about to give her a episiotomy. And I was like, no. And so she was like, oh, she doesn't want that? We didn't ask her first, right? So it's like, and then she finally asked her, do you not want an episiotomy? She was like, no, I don't want one. And so like, even like those small things, really being able, we have to be watchful when we're in the room, but also have those conversations with the doctors and the nurses and the staff as human beings, because they are human, and we really want things to change, but how can we change that? We can't do it by ourselves. We really need to be able to work together to get those things done.
But you have seen improvement in this area?
Mm-hmm. I've seen improvement in the relationships.
In the relationships. Mm-hmm. Okay. And Dr. Bostock, when you hear Candace say that it really mattered to her to not only have a doula who looks like her, an OB who looks like her, as a white doctor, that I imagine that doesn't bother you hearing that?
It doesn't bother me hearing that, right? What I want is for people to feel safe, protected, and like they have the power to determine their own course in this place, right? What we know is that the outcomes are better when people don't have fear and when they're approaching these processes, whether that's pregnancy or delivery or the care afterwards, right? That fear generates a lot of cortisol. And when that cortisol is there, everything goes off kilter, right? And so things that reduce fear, whether that's a provider that looks like them, whether that's a doula that looks like them, whether that's nurses who look like them, is all to the good. And I think that's the direction we need to work in.
In a moment, we'll take a break, and the only break of the hour. We'll come back, and we'll welcome more feedback. But the first one, and I want to hit this before the break. So let me ask the panel about this before we go to break here. Patrick wrote in to ask, what does a doula cost? And that is actually, in some ways, a two-part question, because in general, there's a question of what a doula might cost. And then there's a question of whether there is support for people who can't afford a doula, whether they can get that kind of support, whether there's a system that can provide that. So I'll start by asking Phyllis Sharp, who's a certified doula with Royalty Birth Services. I'm sure people ask all the time, what's it cost to hire a doula? Let's start with that.
It can cost anywhere between $1,000 and $2,000,
okay,
depending on the doula. And then also, if you have any of the Medicaid plans, the MCOs, Blue Choice Option, MVP, and if you have the Essential Plan as well too, having a doula is at no cost to you.
And you know that to me, as an ignorant person who really first heard about doulas when my first son was on his way, I don't think I heard any kind of subsidized support for doulas, years ago. Is that correct, Dr. Bostock?
That's correct.
So this relatively new.
Relatively new.
Yeah.
I think our own Senator Samara Brooke has been a huge champion of this for the women of our state, and this is something, I'm trying to remember the numbers, but I think there are 26 states that now support Medicaid or public assistance for doulas for those people on Medicaid and managed Medicaid plans. So this is something that's spreading. We need it in more places, but we have it here.
Okay, and so $1,000 to $2,000. And Candace, when people ask you if that would be worth it, if they've got the means to afford it, you tell them what?
Yes, do it, or figure it out. Make sure you have the doula in the room.
Okay. After the first child was born, do you think you could have convinced your husband to get trained up enough to do what Phyllis did?
No. No, but everybody's situation is different. My husband, he's lovely, but this isn't his thing. He'll be there, support me, grab whatever you need. Mm-hmm. You can squeeze my hand till it fall off, but we need it, Phyllis.
See, I like the idea that your husband was confident that you were doing well enough that he could have told Phyllis on the phone, no, she's good, while you're wailing in the back. And I'm sure it's not because he doesn't love you or care about you.
Exactly.
Because it's hard the hard part for us, I know it's so hard for the dads, but the hard part is like figuring out how to support, how to help. Mm-hmm. And I will say about what doulas can do is they can provide a lot of support for not just the mom, You want to add to that a little bit there?
Yes, we totally support the partners as well, too. And we teach them how to support. We teach them how to advocate. That's super important as well, too. For me, it's like when we're in the space and a doctor says, well, we want to check you. And mom says, I don't want to be checked. And I said, well, we need to check you. Dad can say, she said she didn't want to be checked. Very nicely. I don't have to say anything because all they need to hear is a little bass in the voice and it goes away, right? And so for me, it's all about like teaching them to help mom. And it's like I tell them all the time, I'm like, I don't know what to do. I'm not a doctor. I can't. It's not about you being a doctor. What it's all about is that you know her better than anyone in the room. So if she says something's wrong, then you should believe her and not let them dismiss her. And so that's what I try to teach them. It's like you need to make sure that you are advocating for her, that you're listening to her, that you believe her number one, and you know her better than anybody else in the room. So you can help be a better advocate than even I can be for her.
Okay, and the follow-up to Patrick's question, and then we'll go to break here, and then we'll welcome more feedback on the other side, is if we had even more support for doulas. Number one, if there were more awareness and more people just knew about this and were willing to hire them if they had the means, or if there were more subsidy and support to provide doulas for people who need them, are there enough doulas and people doing the work? Or would there have to be a pretty big expansion? Boy, you both had pretty strong reactions. You want to start, Phyllis?
There is not enough doulas.
Not enough doulas.
There's maybe, 300 to 400 doulas on the Medicaid list in the whole state. And so we can't do it all. And then like once you're just on the list, then you have to sign up for each MCO to get paid from each one. So if they have Fidelis, you have to sign up for Fidelis. And so it's not it's not really a difficult process to do, but it does take some time. And then we're doulas, we're not billers, so we have to bill ourselves as well too, bill for ourselves as well too. So that is another toll that it also takes. So really working on making that whole process easier so that more people will sign up to be to take Medicaid and essential plan clients as well too. It's very difficult. I talk to a lot of doulas. I'm the president of the doula co-op here in Rochester, so I talk to a lot of doulas, black and white as well too. There's not enough Hispanic doulas, people that speak Spanish. There's two, literally two.
Wow. In
Rochester that speak Spanish, and one's on my team, and I get calls constantly for doulas that speak Spanish. And she can't do it. She can't take care of every Spanish-speaking person in Rochester, right? And so it's like not only just for black persons, but it's also for every single nationality that has a different language here. They would like someone that looks like them and speaks the same language as they do as well too. And we just don't have enough people.
Dr. Bostock, you want to add to that?
Yeah, I just wanted to add that there are several active doula training programs in the community that are ongoing. One that Phyllis is involved in and heading up and running that I think has a contingent of 20 doulas being trained right now in a collaboration with Excelis. So there is active collaboration, again, between health systems, payers, the doula community, the health community to increase the number of doulas in the community.
How long does training take?
The one that I am teaching now is 20 weeks.
20 weeks.
Mm-hmm.
And you can be certified after 20 weeks?
They still have some certification stuff to do, but they'll be trained doulas.
Okay. On the other side of this break, we've got some more questions about what the data is telling us about these problems, and also we'll welcome questions from the audience. We're talking to Phyllis Sharp, who's a certified doula and the owner of Royalty Birth Services, and a 3-time client, Candace Williams, telling her story. Dr. Elizabeth Bostock is with us, and OB GYN with Rochester Regional Health, and we'll come right back on Connections.
Support for your public radio station comes from our members and from Bob Johnson Auto Group, believing an informed public makes for a stronger community. Proud supporter of Connections with Evan Dawson, focused on the news, issues, and trends that shape the lives of listeners in the Rochester and Finger Lakes regions. BobJohnsonAutoGroup.com. And Teen Empowerment, presenting its annual community luncheon, marking more than 20
seconds.
In Rochester, Wednesday, May 6th at the Riverside Convention.
5, 4, 3, 2.
/Rochester.
This is Connections. We are on the road today, and if I forget to say it, I'm going to say it now. We have an amazing team doing technical work who have put this together, and we're so glad to be welcomed by the team from Common Ground Health, the combined entity of Common Ground Health, Finger Lakes Performing Provider System, sometimes called FLIPS, and Rochester Rio. They have welcomed us, but the people who I can't even name, they are numerous. They have really worked hard, and Connections is glad to be on the road. We are going to be doing more on the road with live audiences, more out in the community. If you've got ideas, listeners, you want us in different places, let us know, and we'll see what can work. But just thank you to the team who have put this together. That is way over my head, but they are just the best in the business. And we're glad to be here. In a moment, we're going to take some audience questions from folks in the building with us live here. One other question for Dr. Bostock before we do that, because, again, part of the reason that we are here is there is a disparity in the data on the outcomes here. And we've been talking about what doulas can do in the moment of birth and in the hours of birth and labor and delivery, about pain management, communication, et cetera. But is there enough data that also says when they're there, they can save lives, that we're going to have different outcomes if we've got doulas in the room there, if we've got more support in the room?
Yeah, there's pretty significant data out there. And I think the place where, or the data element we have most studied right now is actually in reduction of cesarean sections. Involving a doula in your birth can reduce your cesarean section rate anywhere between 25 and 40%, which is a pretty significant reduction. And again, if you could reduce your diabetes by 25 to 40%, nobody would question whether you got to take that medicine or not, right? So we shouldn't question whether we use doulas in this situation if they can have that kind of impact.
And for listeners who may be sensitive about this, they might think, look, I had a C-section, it went fine. What I hear from you, correct me if I'm wrong, is not a condemnation of C-sections. It's an observation that if we can reduce the number of C-sections, that is, in general, a desirable outcome, while knowing that some cases need to end up in C-section. Is that correct?
That is correct. Absolutely, C-sections are sometimes needed for the health of the mom or the health of the baby. Nobody would dispute that. But in our country, the C-section rate is too high without a resultant increase in better outcomes for moms or babies.
What's the C-section rate right now?
The overall C-section rate in the country hovers around 35%.
Okay. Phyllis, do most of your clients want to avoid C-section? Do they tell you that?
Oh, yeah.
Yeah? Yeah.
They want to avoid it.
That's one of the regular goals.
Mm-hmm.
Okay. And so that's a common conversation throughout what can be a very long delivery process.
Yes. And so we talk about that. We talk about, what ifs, some of the things that may happen that may, cause them to be in that position that they need to have a C-section for whatever reason. Doulas can't stop that, which some people think that we can, but we can't stop that from happening because we don't know. Baby or mom may be in danger and they may need to go in that direction. But we talk about that as well too.
Okay. All right. In the audience here, David's got a microphone. Let's start. Oh, hello, Phyllis. Go ahead.
Hi. Thank you, ladies, for all the information you're sharing. I have a question. I do a lot of work around health literacy and helping people manage their care. And I know that has a great impact when people have information and know how to apply it before the situation arises. So what capacity are people being educated, women, prior to being pregnant? Is there are there programs? Are the doulas able to get paid for teaching people, potentially pregnant women, and teach these things before they get pregnant versus having them come in afterwards when the person is pregnant and then they're working with them? But why are we not doing something proactively so that the person themselves, the woman who's pregnant, comes in with the right questions, the understanding, the information, and that doula can support that and support her as she advocates for them within the medical system.
Okay. Someone want to start here?
I'll go ahead and jump in on this one, and I hope you'll allow me to call this preconception.
It's a call back to the last hour. For anybody who missed it, yes, it is.
But yeah, I think it would absolutely, that's the place we need to focus in order to decrease the severe maternal morbidity crisis. I don't really know of doulas being involved in that space, but that is a space where community health workers can really have huge impact, and that is a set of programs that Common Ground Health has run very successfully. Common Ground Health's own Jackie Dozier runs a wonderful program with teen moms, or not teen moms, but teenagers and their moms, to do that kind of education. So I agree with you, that's the place where we can have huge impact.
Okay. Thank you very much, Phyllis. As the mic moves down to the front here, let's take a phone call, and then we'll come back to the live audience. And I think we have Virginia in Scottsville on the phone. Go ahead, Virginia. I'm not hearing it here, guys, in studio. We'll see if we can get that switched over. Do we have you there, Virginia? There you are. Go ahead.
Okay. I wanted to comment on an experience that I was involved in. My grandson and his partner, who live in Arizona, I gave them a gift of a doula for both of their children, who are now 9 and 11. Mm-hmm. And it was a very, very valuable experience. The doula was there before the birth, and she was there during the birth, and she was involved in home visits to help them with accommodating their new family members. It was a very valuable experience, and it was the best gift I could have given them. And I would encourage grandmothers to consider that as a possibility if they have that level of relationship with their grandchildren, that they can talk to them about it and find out if they're interested and then do that.
All right, Virginia.
Okay, that is all really that
Thank you, Virginia. Virginia and Scottsville. So I saw Candace nodding. So here's an idea. People wonder, what should we get the new parents when a baby's born? Instead of that, get the new parents a doula. What do you think?
100%. And as she was speaking, all I could think of, that was similar to my experience. Because at the time when I was having children, me and my husband, we weren't the most financially secure. And so because of the village we had around us, we were able to make this happen. So that was super helpful. And then coming home from the hospital, even though the hospital was very hands-on with trying to help you breastfeed, my baby still wasn't latching. But Phyllis would come once I was home almost, I think, every other day or something like that. And she was able to help me get latched. And I was super successful breastfeeding him for at least a year and a half.
So absolutely yes, Virginia. And have people hired you as a gift? Are you aware of that happening in the 400 births you've done?
Yes, I do encourage people because they look at the prices and they're like, I'm like, listen, you're going to have a baby shower? That should be on your list. Like, why is not that a doula? If you really want to do it, why is that not on your list? And then also, if we're in preconception mode, why aren't we preparing, right, for a doula as well as two? We really want them to prepare for everything. And like I tell my clients, I have one client, she took 2 childbirth classes and she was going to take a third. And I was like, girl, if you take another childbirth class, why are we getting so prepared for childbirth? We haven't got prepared for postpartum. It's so many things we aren't prepared for, but we think about this one thing and we hone in on it. But how are we doing? We know that we want to doula if we get pregnant, but we're not preparing for it as well, too. So we save money to buy a house. We save money to buy a car. Save money for a doula service as well too. So there's all kinds of ways. Like I said, and gifting is one of the best ways in the world that you can give a gift to your friend or your daughter, your niece, your nephew, any of those people.
Put Phyllis Sharp on your registry. There you go. In the audience here in the room there. Go ahead.
So I had a question in regards to as doulas become more and more acceptable with doctors and in hospital settings, how do you guys go about keeping the mom's wishes in mind and the best interests of the family? Like, how does that not get convoluted in the relationship with the hospital?
It's a very good question.
Well, the hospital staff and the doctors they respect a birth plan, even if it's outrageous. They will do their best to make sure that all of their dreams come true, just like we do. And if we have to make a shift, we have to make a shift. But I think too, like, if they have a doula and the doula is talking to them before they have the baby, they know that things may shift, and they may need to change their plan as well too. So sometimes I have people that are strict planners and they make a plan. I call it birth wishes just for that reason, because I don't like the word plan. Because when we think of a plan, we think it's going to go this way, and this way, and the baby runs the show. The mom really does not run the show. She thinks that she does, but the baby runs the show. So whatever's going on with that baby, that's what's gonna happen. So we need to make sure that everyone understands that things may shift in that process, and that we may have to shift your birth plan a little bit. And that's okay. And what we want to do is have those conversations with you about why things need to shift. And I think making sure that you guys are really coming together and you feel like you're a part of the decision making turns everything around. You feel so much better about, even if you end up having a C-section, you feel better about your birth experience because you felt like you're involved in the plan, instead of a doctor coming in and said, we need to go for a C-section now. And you're like, oh my God, what's going on? And then you're like, totally, it's like a whole different story than if you come in and said, this is what's going on with the baby. We think you may have to shift to a C-section, and then we're going to wait and see what happens, and then we're all talking about it. You totally understand what's going on, and you're in agreement with it. That's a totally different story, right? Than if you had somebody just walked in the room and said, we need to do this now. It's very, very upsetting when that happens. And so what we want to make sure is that you know exactly what's happening all the time, each step going through, and make sure that the staff is really communicating with you as well too.
Thank you very much. Yeah, thank you. And I think we've got a question down here, David. While we do that, I'm going to read an email from Joel, who says, Phyllis Sharp is wonderful. No question. Just wanted to share love for Phyllis. She helped with our son. He was our first child, a high-risk pregnancy, early delivery, NICU baby. He's now 3.5, healthy as can be, and we just got home from the playground. Philip is awesome. Support doulas and support women of color, from Joel.
Aww,
so
that's beautiful.
Thank you, Joel. You got applause from the audience for that email, Joel. Thank you. Go ahead.
Yes, my question is, I know we're coming off the tail end of National Maternity Health Week. And as we know, Black women are 3 times as likely to die, due to pregnancy-related complications. Have you, either of you, Phyllis or the doctor here, seen any reduction in maternal mortality of women that are working with doulas?
I don't know if that data has actually been, that data may be out there. I am not aware of it. I think the data on the impact of doulas is still early in its inception, so I think those are studies that are likely to happen over the next several years. We'll have more data about that. But what I would say is, we're coming off a really wonderful Black Maternal Health Week that really celebrated justice and joy, meaning we're going to have joy in Black communities, Black births, despite the fact that there is this crisis going on, and we're going to deal with the crisis. I think what we have seen in the statistics is that severe maternal morbidity and maternal mortality have been increasing over the last decade countrywide. I did see some data from the state recently indicating that finally in the last year, we may be turning back down on that again. The disproportionate share of that is being borne by Black mamas and mamas over 35. So I think we need to think about why that gap is widening and address that. I think the question of whether doulas will be able to help us impact that is one we'll have to really look to the data for, but we believe that that will be true.
Okay. Anything to add, Phyllis?
I don't have anything to add.
Okay, very good. It was a great question. I think we've got time to grab one more phone call, and this is from Shirley in Rochester. Shirley, if you're there, go ahead.
Thank you for taking my call, Evan. My 3 children were born by cesarean back in the dark ages, and it was once a cesarean, always a cesarean. My question, however, is what are the physical requirements of a doula, and is there an age limit for women becoming doulas?
Shirley, thank you. Phyllis, you want to take that?
You just have to be trained. There's different types of training out there. The one that I'm participating in right now is with Health Connect One, and it's 20 weeks long. You can do a training that's 3 days long. So it just depends on who you want to be trained through. And also you can be any age that you want. I started this, I was 55 years old when I started being a doula full time. So there's no age limit. Your girl, just do what you want to do. It is a calling for me. So for me, starting this whole business to me, it's not about how much money I make. To me, it's all about supporting families, being there for them, being consistent for them as well too. So it's like, it just totally depends on like what you want to do, what you feel called to do, and be there. Just be there for them. And I think if she wants to be a doula, come on, girl. Let's go. Let's do it.
Well, and I just want to add to that different doulas in the community focus on different things. Like some doulas focus on VBACs, for instance, having a birth, vaginal birth after a cesarean. Some focus on the postpartum period. Some focus exclusively on prenatal care. So you can be a lot of different things as a doula.
Shirley, thank you. And I want to thank what has been an outstanding panel talking about this hour. And I will have the audience now thank this wonderful panel here. Thank you, audience, for being here, and thank you all. That's Dr. Elizabeth Bostock, Phyllis Sharp, Candace Williams. Thank you all for sharing your experiences with us here. Look for forthcoming data and report from Common Ground Health, of course. And Candace, continued good luck with those 3 kids, 5, 3, and 1. You got to have a lot of energy, and I'm sure you do. Thank you very much. What great stories today. From all of us at Connections, I want to thank not only the live audience, but the audience everywhere, whatever platform you're finding us on. And special thanks today to the combined entity of Common Ground Health, Finger Lakes Performing Provider System, and Rochester Rio for hosting us on the road today. We're back in the studio tomorrow, but we'll find you wherever you are. I'm Evan Dawson. Talk to you tomorrow.